to HealthInsight's webinar, Depression and Alcohol Misuse in Older Adults, the Role of the Primary Care Provider. My name is Susan Yelton, and I am the Project Manager for Behavioral Health Improvement at HealthInsight, New Mexico. For those of you not familiar with HealthInsight, we are the Quality Innovation Network Quality Improvement Organization contracted by the Centers for Medicare and Medicaid Services, or CMS, serving the states of New Mexico, Nevada, Oregon, and Utah. One of the tasks we are funded for under our current contract is to reach out to primary care providers to increase the rates of depression and alcohol misuse screenings. Conducting these screenings annually is a best practice standard according to CMS and the U.S. Preventive Services Task Force, and according to CMS, less than 1/3 of those with behavioral health disorders receive treatment for them. Not only does screening benefit patients, Medicare will reimburse primary care providers for screenings, as well as for brief interventions with patients who overuse alcohol. And I'll talk about that a bit more at the end of this presentation. Today, we are pleased to have with us Laura Tomedi and Jessica Reno from New Mexico Department of Health. They will be presenting on the epidemiology of alcohol use and depression in older adults. Before we get to our speakers, HealthInsight New Mexico Medical Director John Seibel will be giving a brief introduction on the need to screen older adults for depression and alcohol misuse. For CME purposes, I do need to inform you that I, Dr. Seibel, and our guest speakers do not have any relevant financial information to disclose. Dr. Seibel, as I mentioned, serves as HealthInsight New Mexico's medical director. He is a licensed and practicing endocrinologist with more than 40 years of experience. Dr. Seibel is a past president of the New Mexico Medical Society and an ex-chair of the prestigious Specialty and Service Society Caucus of the American Medical Association. Originally from Minnesota, he has served as medical director for Aetna Medicare and Blue Cross Blue Shield of Arkansas Medicare Part B. Dr. Seibel has been with our organization in New Mexico for nearly 12 years. The objectives for this portion of the presentation are that the attendee will be able to cite risk factors and signs of depression and alcohol misuse in older adults and articulate the need for depression and alcohol misuse screenings. And I will now turn over the introduction to Dr. Seibel.
Thank you very much, Susan. The first thing you might ask is, why are older adults at risk for depression and alcohol misuse? There's actually multiple reasons for this. Among them are that older adults tend to have health problems, either existing health problems or they develop them as we go along. This results in aches and pains and frequently in decreased mobility. They also suffer from loneliness. Many are living alone and they have reduced social circles. Some have experienced the loss of a spouse, friends, and other loved ones. They also tend to have a loss of sense of purpose. Recently retired, many of them don't have much to do to give them a sense of purpose. Their family has grown up. Frequently, the family has moved away. And as they grow older, they find they can't do things that they used to do when they were younger, and they find this very depressing. They also have problems with worry and fear. They're afraid of aging and somewhat afraid of dying. They're also afraid of becoming a burden on the family. Many older adults retire, and they really do feel they don't have enough money to take care of them in their older age. So we need to start looking for signs of depression in the adult population. feelings of hopelessness or helplessness, anxiety and worries, lack of motivation or energy, irritability, a very common symptom, trouble getting along with people. They'll have a loss of interest in socializing and hobbies, and unexplained or aggravated aches and pains, memory problems. Frequently, they'll have slow movement and speech, and one of the more noticeable things is they start to neglect their personal care. We also have to look for signs of alcohol abuse in this group. And alcohol abuse, of course, is a frequent cause of depression. Signs of alcohol abuse, not dependence, not addiction, but abuse, are heavy drinking, binge drinking, drinking daily, drinking to self-soothe, drinking in dangerous situations such as drinking and driving, or mixing alcohol with prescription drugs is a very common problem with the elderly. Relationship problems frequently cause them to drink, especially if there's fighting within the family. Legal problems, especially if they have a DWI, and neglecting their responsibilities. So why is screening important? Well, older adults are used to being the caregivers, and they may not share their feelings and concerns with their family or their friends. Older adults may not realize that they need help, and they'll have a denial or a rationalization of their behavior. Older adults may not have anyone to talk to about their concerns, and screening will help identify these patients before it is too late.
Thank you, Dr. Seibel. Now we will go to the first of our guest speakers, Laura Tomedi, who will be presenting on the topic of alcohol use, alcohol misuse screening, and brief interventions in the primary care setting. Dr. Tomedi is the Centers for Disease Control and Prevention funded alcohol epidemiologist with the New Mexico Department of Health. She currently chairs the Alcohol Subcommittee of the Council of State and Territorial Epidemiologists and is a member of the New Mexico State Epidemiological Outcomes Work Group. She received a Master of Public Health degree from the University of New Mexico and her doctoral degree in epidemiology from the University of Pittsburgh. The objectives for this portion of the presentation are that the attendee will be able to cite regional statistics on the prevalence of alcohol abuse in older adults, perform the one-question alcohol misuse screening recommended by the National Institute on Alcohol Abuse and Alcoholism, and describe brief interventions for alcohol misuse, which can be provided by a primary care provider. I am pleased to turn this portion of our presentation over to Dr. Tomedi.
Thank you, Susan. My name is Laura Tomedi, as Susan said before, and I'm the alcohol epidemiologist with the New Mexico Department of Health. I'm going to be talking specifically about alcohol screening and brief intervention, or ASBI, among older adults. Just a little bit of what I'm hoping to cover today. I'm going to talk a little bit about some of the epidemiology of excessive alcohol consumption and alcohol-related harm among older adults, screening for excessive alcohol use among older adults, and some of the screening tools that have been recommended, for example, by the United States Preventative Services Task Force, recommended brief interventions and referral for treatments for those who screen positive for excessive alcohol consumption, and then I have just a couple of resources to recommend to clinicians. So alcohol is considered a public health issue. Excessive alcohol use is the third leading cause of preventable deaths in the United States. It adds up to approximately 88,000 deaths in the U.S. each year. And alcohol is also very costly. The cost of excessive alcohol use was almost $250 billion in 2010. And when we say excessive alcohol use, we include both binge drinking, which I'm going to talk about in more detail a little bit later, heavy drinking, which is 8 or more drinks per week for women, or 15 or more drinks per week for men. And there are some populations who we think really should not be drinking at all. So excessive alcohol would be defined as any alcohol consumption by pregnant women, or anyone on any alcohol consumption for persons who are under the age of 21 years old. And an important fact that we try to sort of remind people of is that when we speak about excessive alcohol consumption, that we are not necessarily talking about alcohol dependency. And in fact, 90% of people who excessively drink are not alcohol dependent. So what is considered one standard drink? A standard drink is an important educational tool for both clinicians and for patients because frequently people will go to a bar, will order a drink, and not realize that that drink actually has maybe 1.5 to 2, sometimes even 3, what we would consider standard drinks. And so then when we talk to someone about their alcohol consumption, they may report, oh, I only had 1 drink, but it actually had 3 ounces of 40% distilled spirits. So what we consider a standard drink size is 12 ounces of 5% beer, 8 ounces of 7% malt liquor, 5 ounces of 12% wine, or 1.5 ounces of about 40% or 80 proof distilled spirits or liquor. So for example, gin, rum, vodka, or whiskey. So how do we define binge drinking? Binge drinking is the excessive drinking pattern that is alcohol consumption that brings a person's blood alcohol concentration, or BAC level, to 0.08 or above. So it usually corresponds to about 4 or more drinks per occasion for women, or 5 or more drinks per occasion for men, generally within 2 hours. Binge drinking is the most common pattern of excessive alcohol use. 92% of adults who drink excessively report binge drinking. They may also report heavy drinking, and they may also report alcohol dependency as well. And also there's a couple of different ways that we can measure binge drinking. So we can measure binge drinking just as the percent of the population that meets the criteria that I listed above. We can also talk about the frequency, or among those who do drink, among those who binge drink, the number of occasions that they've binge drink on, that they have excessively consumed alcohol. So for example, a person who has only had 1 binge drinking episode in the past month is at much lower risk than someone who has had 4 or 5 binge drinking episodes in the past month. We can also measure binge drinking using intensity, which is sort of among those who binge drink, the number of drinks. So similar with frequency, a person who just barely meets that criteria, so a woman who had 4 drinks on the last time that she went to drink, on her last drinking occasion, is going to be at high increased risk for alcohol-related harm. However, her risk will be much lower than a woman who consumes 12 drinks on one occasion. And this is important, especially when we start talking about older adults. And the reason why is that if you look at different measures of binge drinking, we can actually sort of see where the risk for older adults lies. So this graph here is prevalence and frequency of binge drinking among adults by age group, and this is for the United States. And if you look at 18 to 24-year-olds, the large green bars are the percent of adults in that age group who self-report binge drinking in the past 30 days. So as you can see, adults 18 to 24 and 25 to 34 are at much higher risk for being binge drinkers, for sort of meeting that criteria, than adults who are 65 years of age or older. However, if you look at that green line that sort of spans across the bars, that's the frequency. So that, again, is the number of times that someone has met the criteria for binge drinking. So while adults who are 18 to 34 are at much higher risk for being binge drinkers, among binge drinkers who are 65 years of age or older, they are much more likely to drink more frequently. And so they're those who do binge drink are at very high risk for alcohol-related harm. And also, and we see that when we actually look at mortality statistics. So this is alcohol attributable deaths by age group in the United States for the years 2006, 2010. We sort of keep track of number of deaths due to chronic causes and then also due to acute causes. So chronic causes, for example, would be chronic liver disease is the most common. Acute causes would be more sort of injury deaths. So motor vehicle traffic crashes, and deaths such as that. And as you can see, especially for chronic causes, adults who are over the age of 65 years of older are at very high risk for alcohol-related death. And actually they are at high risk for both chronic causes in that dark green line and at high risk for injury death, which is in that light green line there. And if we look at alcohol attributable death rates by state, New Mexico, which is my home state, we unfortunately have the highest alcohol attributable death rate in the United States by far. Alaska is our closest neighbor, unfortunately. However, you can kind of see a pattern that there's much higher alcohol attributable death rates, especially in the western states, sort of the more rural and frontier states. And the theory on this is that there's some access to healthcare issues that could be contributing to increasing the risk of death in these states. So what's something that we can do? Alcohol screening and brief intervention is a wonderful tool available to clinicians. Alcohol screening and brief intervention, or ASBI, is essentially assessing a patient's drinking patterns, so that's the screening component, and then providing feedback to about the risks of excessive drinking and a short conversation about changing drinking habits to those who screen positive. And then for the very few patients who do meet criteria for example, alcohol dependency, may need additional assistance, a referral to treatment when appropriate. And then also their ASBI can also be conducted using electronic devices. It is known as electronic screening and brief intervention, or ESBI. The idea behind this is that you can use computers, telephones, mobile devices to facilitate the delivery of ASBI in a clinical setting. And the reason for this is that we recognize that clinic can be very busy, clinicians are very busy, and there's a lot of demands on their time. So this is something that a patient could even do in the waiting room while they're waiting to be seen. And why is this important? Again, we recognize that we ask physicians to do a lot of screenings. So why alcohol screening and brief intervention? And the reason being is that the National Convention, the National Commission on Prevention Priorities ranked alcohol screening and brief intervention as one of the 5 most effective clinical preventative services. And as to who recommends this, the U.S. Preventative Services Task Force, this is a B recommendation. It's based off of their literature review, the systematic review of 23 alcohol screening and brief intervention trials. They found that consumption decreased, alcohol consumption decreased. They also found that there was a decrease in the number of adults who reported heavy drinking, and an increase in the number of adults who reported moderate drinking. So we don't necessarily need people to completely, or not everyone, to completely stop drinking, but we do like to see sort of those increases in moderate drinking, especially if they are folks who were excessively drinking before. And studies generally excluded people who did meet the criteria for alcohol dependence. And this is going to be an important factor that I'm going to talk about a little bit later. So as a result, the USPSTF has recommended, again, it's a B recommendation, which is the same as mammography, that clinicians screen all adults age 18 or older for alcohol misuse and provide them with a brief counseling if they screen positive. The sister organization to the Preventative Services Task Force is the Community Preventative Services Task Force. The Community Preventative Services Task Force tends to look at these issues more on a community level. And whereas USPSTF tends to look at prevention measures more on a clinical level. But Community Preventative Services did a systematic review of electronic screening and brief intervention. They looked at 31 studies, and they found that sort of on a population level that there was a reduction in binge drinking, a reduction in binge intensity, and a reduction in sort of peak consumption, or the most that a person drank, and including some BAC measurements among excessive drinkers. And so they recommended electronic screening and brief intervention as well. And as a result of this, the CDC has really been trying to get the word out about screening and brief intervention. They released this vital signs, I believe, in 2014, looking, sort of breaking down some of especially the national data on alcohol screening and counseling, and trying to provide providers with a little bit of just sort of brief statistics to keep in their pocket. So, for example, alcohol screening and brief counseling can reduce the amount consumed on occasion by 25% in those who drink too much. And this can be a really great resource, especially an educational resource for providers who are trying to implement ASBI in their practices. So I wanted to really briefly just quickly sum up that ASBI is most effective among adults who are binge drinkers, and it is not necessarily a recommended practice for adults who are alcohol dependent. And however, for 90% of excessive drinkers, this is an incredibly effective intervention. And if we look specifically at ASBI among older adults, effectiveness, there have been a number of studies that have looked at the effectiveness of ASBI specifically among older adults. So for example, in a randomized controlled trial of 3 primary care sites, they used sort of a multifaceted intervention that included ASBI, and they found that it reduced alcohol consumption specifically among at-risk drinkers. And then is a kind of an interesting new study that was recently released in the American Journal of Public Health. There's the Florida BRIGHT, or Brief Intervention and Treatment of Elders. And this looked a little bit outside the box at using alcohol screening and brief intervention. And they included aspects of prescription drug misuse, which is a real issue in this population, and depression. And they included ASBI in a number of different facilities. So where participants lived, for example, senior housing or received aging services, and they found decreased substance use even 6 months after the intervention. So how are we doing as a nation at implementing this intervention? And unfortunately, the answer is not great. So we ask on one of our large health surveys from time to time, has a doctor or other health professional ever talked to you about your alcohol use? So this isn't even sort of, have they formally screened you for binge drinking, or provided intervention, but just have you had any conversation about your alcohol use with a healthcare provider? And as you can see, especially among adults, the green bars, the dark green bars are if they were ever asked, and then the light green bars are if they were asked by a health professional during the past year. And as you can see, especially adults over the age of, who are 65 years of age or older, there are very low rates of adults being asked about their alcohol use. However, they, as you can remember from the beginning of the presentation, they are very high risk for alcohol-related death and harm. So now I wanted to talk just a little bit about some of the screening tools that have been recommended by USPSTF. The 3 screening tools that that agency recommends are the Alcohol Use Disorders Identification Test, or the audit, the abbreviated audit, and then also there's a single question screener. So the audit is about 10 questions. It takes 2 to 5 minutes to administer. It is very specific and sensitive. The abbreviated audit is also very sensitive and specific, but it's only 3 questions and only takes 1 to 2 minutes to administer. NIAAA has recommended a single question screener, which is essentially how many times have you had a binge drinking episode in the past in the past year. And so they, the question specifically is, how many times in the past year have you had 5 for men or 4 for women, and or more drinks in a day? And as you can notice, they actually recommend 4 drinks per day, or excuse me, 4 drinks per for any adult over the age of 65. So this single question screener is really intended to be as easy as possible. So it takes less than a minute to administer, and while the sensitivity and specificity isn't quite as good as the audit or the abbreviated audit, it is adequate to meet the needs of being able to screen patients. And then when we talk about brief counseling, which is the intervention, USPSTF defines a couple of different sort of intervention intensities, such as very brief single contact, a brief single contact, brief multi-contact, and then an extended multi-contact. And they found that in their literature review that brief multi-contact really had the best evidence of effectiveness, whereas one very brief had only limited effect. And they make a very good point that the important thing to know with this screening, with this screening intervention is that the target population are non-dependent risky drinkers. So we're really trying to get at the 92% of excessive drinkers who are binge drinkers. And there are a number of different ways that physicians can engage with their patients about excessive alcohol consumption. So if someone screens positive, there are a lot of ways that you can talk to them. However, one of the best recommended is brief motivational interviewing, and there are a number of training tools available to providers to give them very specific prompts and wording that can be used during the brief motivational interviewing. So just as a really quick little side note, for most patients, the brief intervention is incredibly effective. However, some patients may require more assistance than a brief intervention and need to be referred to alcohol treatment. And a good resource for physicians who just want to make sure that they want to be prepared for that situation is NIAAA's Helping Patients Who Drink Too Much, Clinician's Guide, and I've included the web link there. So finally, I just wanted to include a couple. There are a lot of resources on alcohol screening and brief intervention. SAMHSA has a guide. Many professionals or associations, medical professional associations have guides. These are just 2. And one is Expert Among Older Adults, an implementation manual. So this is specifically implementing Expert Among Older Adults. And then the CDC actually put together a really great step-by-step guide for primary care practices to really walk them through integrating this into their practice so that it can be as easy and as painless as possible. And that's the planning and implementing screening and brief intervention for risky alcohol use. So I want to thank everyone for your time, and I'll pass it back on over to Susan. Thank you.
Thank you so much, Laura. That was some really great information, and you managed to really convey how important the role of the primary care provider is in this alcohol misuse screening and even being able to provide brief interventions. I was really struck by your talking about how 90% of the excessive alcohol users aren't alcohol dependent and can really be impacted just by that screening and brief intervention process, but yet how few older adults have ever even had that conversation with their provider, much less a formal screening. And it really hits home, especially living in New Mexico, which is where I'm from, also a state that has such a very high use of alcohol-related mortality. So thank you so very much. I would like to now introduce our second speaker on the topic of depression screening and treatment among adults. We are pleased to have Jessica Reno with us today. Ms. Reno graduated from La Cueva High School in Albuquerque, New Mexico, before receiving her Bachelor of Science degree from Texas Tech University and her Master of Public Health degree from Emory University. She has worked as an epidemiologist with the Centers for Disease Control and Prevention and is currently the mental health epidemiologist for the New Mexico Department of Health. The objectives for this portion of the presentation are that the attendee will be able to cite regional statistics on the prevalence of depression in older adults and articulate the role of the primary care provider in screening for depression. And I will now turn this portion of the presentation over to Ms. Reno.
Thank you, Susan. I'm happy to be able to present this information to you today. I work with a variety of projects in behavioral health in New Mexico, but today I'll specifically be talking about depression because of the amount of evidence we have about what we can do in the primary care setting to actually prevent depression. So much like Laura's presentation, I'll be talking about the prevalence and epidemiology of depression, including risk factors. I'll be talking about how depression can be prevented in the healthcare setting. And I'll also be talking about some resources available to physicians in New Mexico. So first, one thing that we know nationally and in New Mexico is that approximately 7% of all adults experience a major depressive episode each year. That's been consistent for the past decade. And so that's 7% of adults who are experiencing at least 2 weeks of multiple depressive symptoms, which directly impact quality of life as well as work productivity. So for each age group, this is some information from our survey in New Mexico, where we asked not only about major depressive symptoms, but we include moderate symptoms as well. So 10.2% of all adults experience moderate or major depression at the time of being surveyed. And for adults 65 years and older, 5.3% were currently experiencing depression at the time of the survey. And I do want to note for those older adults that we don't see very much of a difference between male and female adults, so 4.9 versus 5.6%. Now moving on to look at the prevalence of current depression by status of having a chronic physical illness. The difference here is that a much higher percentage of those with chronic illness are experiencing depression, so 12.7% versus 5.6%. That's 2 times for depression prevalence among those who have a chronic illness. And we see the biggest difference in adults who are 65 years or older. So let's go through some of the risk factors for depression. Having a history of depression or other psychiatric disorders increases risk, as well as having a lower socioeconomic status, having a family history of depression, having a history of adverse childhood experiences, and I'll explain those in a little bit. We're also going to talk about the link between substance use and depression. And as I just mentioned, having a chronic physical illness increases risk of depression as well. And it's important to remember among older adults that risk factors for depression can include experiencing cognitive decline, bereavement, and placement in an institution, including residential and inpatient settings. So I just briefly want to talk about having a history of adverse childhood experiences. And what I'm talking about here are having experienced verbal, physical, or sexual abuse or family dysfunction as a child younger than 18 years of age. And family dysfunction refers to things like witnessing domestic violence in the home, having a family member who abused substances, a family member that was incarcerated, family member that had a mental illness, or parents being separated or divorced. So Why is this important to know someone's history? Even as an adult, if you experienced one of these adverse events as a child, you're more likely to experience depression, to have serious job problems, to have serious alcohol problems, and also to have learning or behavioral problems. Okay. So in New Mexico, in the past, we have been able to do surveys that include information about adverse childhood experiences as well as symptoms for depression. And so this next slide talks about something called frequent mental distress, which means in the past 30 days that the person experienced at least 6 days or more of poor mental health. And what we see is that as the number of categories that the person experienced of adverse childhood experiences increases, their prevalence of frequent mental distress also increases from 10.2% among those who experienced no adverse childhood experiences to almost 40% for those who experienced 6 or more. And I apologize, the slides aren't changing. I've lost my connection momentarily. All right, so continuing to talk about frequent mental distress, which is that 6 or more days of poor mental health in the past 30. We can also look at the correlation with substance use among adults. Things like having ever smoked, current smoking status, and heavy drinking are all associated with increased frequent mental distress. So for example, those who currently smoke have a 30% prevalence of frequent mental distress compared to 14.8% among those who don't smoke. Okay, and so the last thing I'm going to go over in regards to risk factors are chronic physical illnesses. And so on this next slide, I just have a list of the illnesses that we're able to track in New Mexico. And as you can see, for everything from COPD and asthma to kidney disease, stroke, arthritis, prediabetes and diabetes, high blood pressure, high blood cholesterol, heart attacks, coronary heart disease, cancer, and obesity, the prevalence of current depression is much higher for those who have physical illness than for those who don't. So if at this point you're thinking, well, you've just described the people that are coming into my office, then there is something that we can do to help people get treatment and also prevent depression in the future. So there's recommendations nationally for what to do in the primary care setting to prevent depression. They come from both the U.S. Preventive Services Task Force, which Laura mentioned earlier, as well as the Centers for Disease Control and Prevention's Community Guide. And there's 2 basic components to prevention for depression. One is screening to identify those at risk, and the other is to connect them with treatment, either in the setting in the primary care office or by referral. So I'll go through each of these recommendations. So this first one from the U.S. Preventive Services Task Force applies to all non-pregnant adults 18 years or older in the primary care setting, and it includes screening patients for depressive disorders and then doing a full diagnostic interview using the DSM for those who screen positive, and then staff-assisted treatment for those who do have a diagnosis, including psychotherapy. And that practice has been shown to decrease clinical morbidity in all adults. So next, let's look at the C Community Guide's recommendations. So their recommendations for screening are typically for older adults or depression. So they recommend active screening for depression, measuring outcomes, training providers for depression care and case management, educating providers and patients about depression and treatment, including antidepressant treatment and psychotherapy, and if possible, a supervising psychiatrist. And this practice sees a 45 to 55% response rate. The second CDC Community Guide recommendation is for all adults 20 years of age or older in the primary care setting, and for linking patients to treatment, specifically having case managers, that providers, patients, and mental health specialists connect so that those people actually receive treatment. And this practice results in improvements in depression symptoms, adherence to treatment, response to treatment, remission and recovery, even satisfaction with treatment, and also functional status. And also provides economic value to clinics. So I just want to go over some tips for screening, first of all. So there's several different instruments that you can use to screen for depressive symptoms. So you can research each of these on your own. There's even a geriatric depression scale that can be used to kind of figure out what would work best for your clinic. But I do want to specifically point out that there's a 2-question instrument that works just as well for screening in the primary care setting as the other instruments, which are longer. The questions are, over the past 2 weeks, have you felt down, depressed, or hopeless? And over the past 2 weeks, have you felt little interest or pleasure in doing things? And if the patient answers yes to either of these questions, then they receive a full diagnostic interview. So the second part of these recommendations is to actually connect the patient with treatment. And so what I've done here is put a list on this slide of things that have been shown to work well in the primary care setting. Anything from including one of these things to all of them has been shown to be effective. So you can kind of go over each of these ideas and think of which ones would work best for you. One recommendation is having a screening nurse appointed who advises the physicians of positive screened patients and provide the protocol and facilitate referral to behavioral treatment. Another idea is having staff and clinician training, for example, 1 to 2 day workshops, having manuals for clinicians to use, having monthly training lectures, providing an initial visit for the patient with a nurse specialist for assessment, education, and discussion of goals, including patient preferences, having a visit with a trained nurse specialist for follow-up assessment and ongoing support, especially for those with medication to help with adherence, a visit with trained therapist for cognitive behavioral therapy after having the diagnostic screening, and also providing reduced copay for those who are referred to psychotherapy. So keeping all this in mind, we know there's some barriers to consider. We want to remember that sometimes patients are reluctant to enroll or be referred to care. Sometimes there's low patient attendance, especially in these rural areas. There's limited insurance coverage for mental health care even today. It's sometimes difficult to locate organizations in the community that offer depression care with whom you can connect with for that referral. And then training specialists from other fields to work with those who have depression and comorbid illness can be difficult. So we want to provide some resources for you. So one here, specifically in New Mexico, there's a course on diabetes and depression for physicians, and it's at this link here. There's 3 CEUs provided, and I will let you know that it expires at the end of December 2015. So if you want to do that, go ahead and do that. And then these are my references from the recommendations that we went through so that you can go to these links and read through if you'd like to on all the details of the evidence and recommendations for implementing these practices in your office.
Thank you so much, Jessica. That was some wonderful information. There were several points you presented that I was really struck by. One was how much having a chronic disease increases risk for mental distress, as so many of our older adults develop chronic diseases as they age, and that these conditions don't even need to involve serious loss of function, as shown by the data you shared, that prediabetes causes 140% increase in the risk for mental distress. Another point that I was struck by was the correlation between heavy drinking and increase in mental distress, which really emphasizes the importance of screening for both conditions, depression and excessive alcohol use. And I'd like to very briefly talk about the current initiative that CMS has funded the HealthInsight Quality Improvement Network to work on in New Mexico, Nevada, Oregon, and Utah. We're working with primary care practices to increase annual screenings for both depression and alcohol misuse. Not only, as you heard, are these important for your patients, but Medicare will reimburse for annual screenings through Part B. And the rates on this slide are just meant as an example to give you a general idea of reimbursement levels. So what these are the non-facility reimbursement rates for New Mexico. We will be helping practices to identify an evidence-based tool that works in their setting and incorporate this into their routine workflow. We'll also be providing training on brief interventions for patients who screen positive for alcohol misuse and successful billing processes for screening and brief interventions. In addition, we will be working on locating organizations in the community that providers can refer their patients to when they are in need of a behavioral health specialist. As part of this initiative, we will also be working with inpatient psychiatric facilities to improve transitions of care for patients hospitalized with a behavioral health disorder, to increase referrals to behavioral health specialists after discharge, and reduce 30-day readmissions. We'll be specifically focusing on improving the inpatient psychiatric facility quality reporting measures for creation and transmission of a continuing care plan and follow-up with a behavioral health specialist after discharge. And again, we will be working with participating communities to develop the referral networks so that there are behavioral health specialists available to refer patients to. I just want to leave you with the contact information for the project lead in each of our states. Please contact us if you're interested in participating, either to receive information on further educational opportunities or for technical assistance. All of our work with practices and facilities is at no cost to the participants, since our work is all funded by CMS. So this concludes our webinar for today, and I want to thank you all so much for joining us. We hope that this information will be helpful to you in serving your patients. You can proceed in the HealthInsight CME portal to complete an evaluation of today's event, as well as to receive your CME certificate. Additionally, if you have any questions for either Dr. Tomedi or Ms. Reno, or if you have any questions regarding the CMS initiative to increase depression and alcohol misuse screenings, please contact your state-specific behavioral health contact or myself, and we would be happy to forward these on. Thank you again, and thank you to both of our wonderful presenters. I hope you have a wonderful day.